I am Heather Nye, and I thank you for the nice introduction. I am probably one of maybe two internists here at this meeting. I don't know, maybe just one of one. But it's really been a wonderful meeting, and so it's a great pleasure to be able to talk a little bit about multidisciplinary care of the geriatric patient. And I view my role today as making sure that we recognize the problem. And I've been to enough sessions at this wonderful meeting to see that a lot of people are talking about this problem. So I don't think the problem is lost on a single person in this room, especially if you chose to come to this talk. We have an aging surgical population. We have worse outcomes in those patients, and we're probably not doing everything we can do to best prepare them. The second thing I want to do is make this a problem that seems more compelling. How do we make geriatrics sexy? It's not easy to do. It's not easy to engage people around the problem who are not in this room, for instance. I think it's important for us to figure out a way. So, and then the final thing is that the speakers that will follow me will dig deeper into some of the areas that are hot topics in geriatric care. I have no disclosures to make. One of the things I do want to say is that there might be some subliminal messaging on some of my slides, some pretty pictures and things like that, to make this topic a little more enticing and appealing to everyone. So, need for a paradigm shift. If you were at the earlier opening talk, the Selden lecture, you heard Dr. Strong say that please don't call this a tidal wave. It was too late for me to change this slide, so I have a wave here. But it's not a tidal wave. This is just the wave of age is what we're seeing in the population. So the data up here of 20% of the population by the year 2030 in the United States, 20% of the population will be in the geriatric age group, over 65. Is this a Northern American problem alone? I think that most people saw through Dr. Strong's talk, this is a global problem. And this slide here from the World Population Prospects shows that the percentage of elderly in all the continents is increasing dramatically. And through 2050, you can see in the Northern American population, somewhere between 25 and 35% of the population. So it's a real problem. And not only are there more older people, but we are seeing more and more higher percentages of elderly people going through elective surgery. And so it's both daunting and an opportunity to better prepare ourselves for this population, because we also have ample evidence that they just don't do as well on so many fronts after surgeries. They have cognitive decline, they have functional decline, they have worse post-operative surgical outcomes, they have medical complications at much, much higher rates than the general population. So this is a population we clearly need to pay attention to. So I'm going to do a free association exercise, and this requires people yelling out things they think of when they see these two things together. Go. Complications. Hip fracture. Poor hearing. Delirium, thank you. Nursing facility, I love it. Everybody else has a blank in their head. Okay, good. So I did this with myself. I was like, what are the first few things I think of? And remember, I'm coming from the perspective of an internist, but we're still thinking the same things. This is not a mystery. No one was thinking about cookies and cream and a pretty little walk in the park. People were thinking about calling the medicine consult, complications, skilled nursing facility, competency, other risks, potentially orthopedic falls, et cetera. So, and hasn't been lost on us. I think the entire room probably had these same thoughts, but just didn't feel like yelling at the top of their lungs. So in 2010 in the United States, a body of experts in geriatrics was convened with about 28 members from different specialties: medicine, geriatrics, anesthesia, and general surgery. Representing them were the societies ACS and AGS, and they reviewed 20 years of literature or so, and then they put together two different publications, the preoperative assessment of the geriatrics patient and the perioperative management, based on on that 20 years of best evidence that we had in caring for geriatric patients in this period. And when evidence was not available, just consensus from experts. These publications were wonderful. They were well received, but they were bereft of interventions that we could really employ. There was a lot of discussion about risk, a lot of discussion about delirium prevention, so that certainly was in there, but less about what we could do about the inherent risks of being frail. So what did they say? They said that don't treat general adults the same as geriatric patients. We really need to change our preoperative evaluation to match the population that needs it. So employing the triad of whole health, I kind of like to look at it as a three-pronged stool, big picture, body and brain. We think about the body and the brain already in the standard pre-op risk assessment, but we take a deeper dive when it comes to geriatrics. And of course, the big picture is exceedingly important in this population because quality of life oftentimes trumps quantity of life when you actually get down and talk to patients about their goals. So what do we recommend for geriatrics patients? This is what they have from their publication, doing a cognitive assessment, which we're going to learn more about, functional assessment, polypharmacy screens, deliriogenic meds, doing nutritional assessments, advanced directives, and from an internist standpoint, what's near and dear to our hearts is really having a deeper conversation about these risks with patients, making sure that they understand them, making sure that their expectations are the same as the surgical expectations and that they match. There are a lot of different groups, at least in the United States and I'm sure globally, making sure that these guidelines get out there in the form of standards of care. The Coalition for Quality in Geriatric Surgery is one of these bodies that has recently come up with the top competencies for any hospital caring for geriatric surgical patients. And they plan to have metrics around those so that we can better start gauging places and how we do with this care. Of course, most of you know the Perioperative Brain Health Initiative. We'll talk a little bit about SPAQI and its support and guidance around frailty, and then just the growing literature. Every single day you see something new about frailty or prehab in the geriatric surgical population. Why? Because we need to know more about what to do next. And so I think in my last few minutes, some of the things that I want to cover aren't so much those topics, which will be covered in depth by my colleagues, but more about how do we operationalize it. It's daunting. It's going to take a village. It's going to take a lot of us, not all anesthesiologists, not all internists. It's going to take all of us to make sure this happens. And this is a graph that I put together for a book chapter that's not out yet, but coming up. On the x-axis, you sort of have increasing resources, and on the y-axis, and on the x-axis, you have time. And if you think about resources and time, it's the two things we have the very least of. And so with these patients, as we start talking about all these interventions, on the left-hand side of the screen here would be the assessments, and on the right-hand side, the things that look like jelly beans, are the potential risk reduction strategies, things that we know about. There's innumerable things, and again, increasing levels of time and resources are needed to do all of these things. How do we pick and choose for our clinics? Who does these evaluations? Who does the interventions? I think that these are questions we just don't have the answers to, and I think the biggest question is who funds all of these activities too? And I do want to make a plug for my wonderful hospitalist colleagues way down there in the right-hand corner. That co-management of the hospital patient after surgery is a very common model in the United States in terms of early recognition of complications. And that is one modality that's been shown to help in this population. So again, other models of care, I just want to kind of briefly go through a few data-driven models that people have looked at. This is just SPAQI's kind of look at the things that we can do in frailty assessment. This came out this past year in terms of their guidance around the different interventions that we could attempt. I'm not subscribing to this. I'm just saying it's one of those things out there that you can look at as a potential model of care. Another model of care some of you may have heard of, this is again in the United States at the Durham VA, which is through Duke University, is the Perioperative Optimization of Senior Health. This is a very robust preoperative clinic involving multiple specialties prior to surgery and postoperatively. And they, in their studies, show that this intervention actually decreased length of stay, decreased readmissions at 7 and 30 days, and patients were more likely to be discharged to home in a functional state with self-care. There were fewer complications in these patients as well, even though they were more complex. So I'm going to skip ahead because it's looking like I'm running out of time here. How am I doing on time? 5 minutes, okay. Michigan Surgical Home was another a successful prehab model that was based 2 weeks or more before a surgery, where patients underwent a home model, which really involved a lot of patient motivation. They looked at psychological, nutritional, physical preparation for surgeries. These patients had a 31% reduction in length of stay, 28% lower costs, because these were asynchronous interventions where patients were actually doing this prehab at home with pedometers and a walking program, so it wasn't terribly expensive on a workforce front. However, when I looked at the data a little closer, these are patients that were highly motivated and highly functional to start with. So these were different patients than the ones that we're the most worried about. This is our clinic at the VA in San Francisco. We have a multidisciplinary. I don't have data to go with it at this point. We're relatively new. But I just put the schedule next to you on the right just to show you how much time this involves. And we don't have nutrition or pharmacy. Other services do. And in our model, each patient has a 2-hour appointment with us. And they love it because they don't have to move. But again, we're not hitting all of the marks here either. And so you can imagine adding even more services to this is going to increase the hours. So there's more questions and answers. Interventions and assessments and which ones to do, we don't really know. They're challenging to operationalize. They're even more difficult to scale. As we see these geriatrics numbers go up, we can't do 4 patients every half day. We need to do more. And we heard from a number of speakers that these interventions that we might do in prehab really need to be tailored to the patient. And this rails against the common surgical protocolized model. So how do we reconcile that? It requires patient engagement, saying, hey, hold the horses, we need your nutrition better. We need people to buy into that and be okay with delaying surgeries. And most importantly, the return on investment is really opaque right now for the people who could fund this because we're talking about very tailored interventions that are difficult to study and difficult to implement and require a lot of resources. So I think it's an uphill battle, but I think we can do it. The last few things I want to do is show some really happy slides. So this is strength here, and the team, this is the Montreal Canadiens when they won the Stanley Cup in 1993. There's got to be a couple of yes. So it's going to take a lot of teamwork, and it's going to take a new, fresh look at the world and thinking outside of the box and what we do in our preoperative evaluation. It's going to take more than a couple glasses of wine, probably frequently, when we're looking and picking through all of this prehab data. What do we do with it? What do we do at our institution? What's best for our patients? And multiple moments of Zen. Does everyone know where this is? This Lake Louise in Banff. I'm going there in a few months. I'm very excited. But it really, it invokes a sense of calm and peace, and we can do this because it's a daunting task. And our speakers to follow me will be amazing. And I think that it may not be the greatest show on earth or the most exciting show on earth, but it most certainly is the most important show. And it takes a village, sometimes a motley crew, and that is internists, surgeons, and anesthesiologists. So thank you.